way that you can focus on your own wellness. When you're feeling like things aren't going very well, if you take a minute and think about one thing that you're grateful for, then it actually changes your brain chemistry in a positive way, apparently, I've been told. The other thing I would say is that ACP Ontario is the only group of internists that I'm aware of who is willing to advocate for things that matter to internists in Ontario. And as the new governor, I'm hoping to build up our ability to advocate effectively for what internists care about. But we can't do that without more members. So if you are looking for a good organization to join, think about it. Just to give you an example of what I want to do, I'm going to be encouraging all ACP members who have a moment to either write or meet with their local MPP to ask them why we are not funding ABPM monitoring. Because ABPM monitoring would actually save the government substantial amounts of money in inappropriate drug utilization for hypertensive patients. There's very clear data that suggests that, and yet the government, in their wisdom, has decided that they're not funding it. And so these are some things that I'm going to be working on. So I'll put the login for this up in a second. In terms of my disclosures, I've done CME events for a lot of companies that make the novel oral anticoagulants, NOACs or DOACs, whatever you like to call it, as well as some other things. But the real thing that you need to be aware of is that Doug Ford continues to try to convince me that I should be preferentially prescribing warfarin to my patients. And he does that by giving me about $600 a month to monitor INRs. So, and that's an ongoing lifetime commitment that he's got to me to sort of support my family and that sort of thing. So, and this event is sponsored by Bayer, who make rivaroxaban, and their interest is obviously in the COMPASS data. And I am going to be talking a little bit about that. So, my objectives today are to look at contemporary and historical residual risk issues, which I'm sure many of you have seen lots of. I'm going to try to compare and contrast some of the options for pharmacotherapy that we now have, and talk about patients who may benefit from residual risk management, and then just talk a little bit about how to prioritize your time in what you're doing. So I want you, if you have the app open, to tell me what you think is, I'm going to try to get these settings off. If I click that, will that go away? I don't know. Oh, hold on. Back. So I want you to tell me the one thing, the most important thing you can do to lower CV risk. And you're only allowed to write one thing into the slide, just to get a sense of where you're at. Okay, so get them to stop smoking. How effective are you at getting a patient to stop smoking? Because I agree, actually. I think if we could get patients to stop smoking, that would be great. But that's part of the equation, is the relative risk reduction if a patient is successful. But you also have to think, if you're thinking about doing smoking cessation counseling, how much effort you are going to have to put in to do that. Because there's also the issue of how you're going to spend your time. Let's see, diabetes management, sure, I've got a little bit of data on that. Exercise. So is there, actually I'm going to show, are any of you familiar, who knows of the Look Ahead trial? Just a show of it. See, nobody knows about Look Ahead because it was suppressed. It was just like that cath study that showed that cathing people doesn't make any difference. Yeah, okay, so we'll talk about that. All right. Okay, fair enough. This is our case, 65-year-old guy who just retired from farming. We have lots of farming in London. I imagine you have a little farming around here. Now that he has ODB coverage, he decides that he wants to go see his GP. He says, when I walk up in the barn one flight of stairs, I get this crushing retrosternal chest discomfort. If I walk, about 80 meters over towards the barn, I actually have some bad kind of crampy pain in my calf muscles. He's actually a tobacco farmer because he's from Tillsonburg, and that's where we farm tobacco. So in order to support his industry, he's been smoking a pack a day for, as long as he's been a tobacco farmer. And he says, "Doc, I'm really good, actually. Like, there's really nothing wrong with me. Just these few little issues that I'm concerned about." His BMI is 33. His blood pressure, when you check it using unattended, rested, automated office blood pressure, is 160 over 100. His cholesterol level is 6. His A1C is 8.9%. His EGFR is actually high because he's hyperfiltering from the diabetes. His A1C is his ACR is a little high. His ECG shows some Q waves in the inferior leads. The family doctor calls you and says, I don't know what to do. I know that you can't see this guy right away. I have only 5 minutes until I have to see the pregnant teenager in my waiting room. What should I do? So if you have the app, what should you tell him to tell this patient to do in the next 5 minutes? Should this patient eat the DASH or a diabetic diet and exercise regularly? Should he stop smoking? Should he start an ACE inhibitor? Should he lower his blood pressure in some other way? Should he start a statin? Should he start some kind of glucose lowering medication? Or should he start a beta blocker for this anginal discomfort and make his legs worse? Okay, so we're still going to, even though we don't really believe that it's going to be effective, we're going to tell him to quit smoking, because then it's on him, right? And one of the rules of medicine is always try to blame the patient whenever I'm just kidding. Okay, yeah. So, but these are the kinds of things. But of course, this is a challenging situation. The family doctor did whatever it was, and the problem disappeared from your list of problems to deal with. A year later, he comes in for an aortobifemoral bypass, and you're involved in one way or another in this case. He now actually, with the bisoprolol on board, can get up 2 flights of stairs, so that's better. His PAD has gotten worse, which is why he's having this procedure done. He actually quit smoking. So what you guys who said tell him to quit smoking, he did it. His BMI is a little lower because he's been trying to be a little more active. His blood pressure's better. His cholesterol's better. His A1C still isn't great, but maybe a little bit better. His EGFR is better because you have him on an ACE inhibitor. His drug list is there. You're seeing him in the pre-admission clinic. He can get 2 flights of stairs now. His angina's better. But what are you going to put in your pre-admit clinic visit note for this guy? This patient has done well getting his risk factors in order from last year, and he's stable for the proposed surgery. The patient will die if you operate. I see somebody wants that. This patient does not require cardiac risk stratification because the angina is stable class 2. Patient should have coronary risk stratification before the proposed surgery. So, there's still somebody hanging on there with the die if you operate on him. So, he could die, but anybody can die. Just getting in your car in the morning, you could die. So, all right, fair enough. So actually it's interesting because in our institution, we would definitely get some form of cardiac risk stratification done. If you look at the guidelines, they actually say in a stable guy like this that it's not necessarily recommended, but I just thought I'd throw this in here to see what you guys think. But you guys are doing the same as what we do. Okay, so anyways, he goes for the surgery, and 3 days after surgery, somebody gets called because he's got increasing shortness of breath. He's got orthopnea, PND. His chest X-ray shows pulmonary edema. His ECG shows diffuse ST elevation. His troponin is 300. His echo shows that his LV is about 25%. His CAS shows diffuse triple vessel disease, and there's really nothing to revascularize at the moment. Clopidogrel is added for better or for worse. We'll say he was genotyped, and he actually responds to Plavix appropriately. His drugs are tinkered with by somebody that likes to tinker with his drugs. So he's on Carvedilol now, and he's on the AIR study ramipril dosing, which is BID. You guys all know that ramipril doesn't work dosed once a day in heart failure, right? And you don't have it on your heart failure algorithm as a once-a-day drug, correct? Yeah, good, okay. In London, we have it as a once-a-day drug. All right, so a year later, you interact with this guy again, And he's on the same drugs, and although it looks like the clopidogrel's been dropped, his EF's a tiny bit better now, his A1C is a little bit better. What are you going to, so this guy is on reasonable drug therapy now. He's kind of got a cocktail of things, and his numbers have all gotten better. So he has responded appropriately to your initial management of risk. The question at this stage is really getting into this topic of residual risk. So even though this guy has done well, he's done everything that his doctor told him to do, he's taking the medications as he should, this guy probably has quite high residual risk, I would guess most of you would believe. So what would you do going forward at this point in this guy? Would you add an SGLT2 to get better diabetes management? Or maybe, because the DAPA-HF study said it was a good idea, would you add furosemide? I can't believe this guy with heart failure is on Lasix. Lasix is a great, like, very evidence-based drug, right? There's tons of data supporting Lasix as a treatment in heart failure. No, there isn't. But would you add a PCSK9 for his cholesterol because it's still a little high? Would you try to get his blood pressure a little lower, aka Sprint? Would you add Entresto for heart failure? Would you add vascular dose Rivaroxaban? Would you just tell him to get his will in order and spend rather than spending money on drugs, spend money on the lawyer? Okay, so far, most people are saying add an SGLT2, add Entresto, add a little bit of, those are probably the Bayer reps at the back. I'm just kidding. I'm just kidding. They're holding their hands up. They're not contributing. All right, fair enough. Okay. So the real question, so this is actually the crux of the issue, and this is why the case is here. There are many options that you have to consider, and what I hope to do in the next few minutes is give you some tools to think about how you would decide which options you're going to pursue. Given that you have limited time, that was not a gun. Okay. Okay. So actually, before we get going, just to make sure I didn't miss anybody's favorite residual risk management, is there anything else that you want me to sort of put on the table? I guess any of you believe in the fish oil thing? It's going to be, the icosapent ethyl is going to be, I think it's about $10 a day. Is the stocks going up? Okay, so we could add that to the list. Anything else that Ezetrol, sure, yeah, as a potential residual risk option. Anything else? All right, fair enough. I just want to make sure I didn't miss anything glaring. Colchis, oh yeah, sure, absolutely. Okay, so when I was thinking about this, one of the things that I thought about is in all of these residual risk studies, are we talking about apples to apples, or are we talking about apples to oranges? And so when you're figuring that out, you put up the baseline characteristics for each of the studies, and in this slide I kind of put up Compass, Empareg, and Entresto. I put up DAPA-HF there because it's an SGLT2 in a different population. And what was remarkable to me when I did this was that we are actually talking about apples to apples, except the heart failure studies. So Entresto and the DAPA, or rather the Paradigm and DAPA-HF are different population of patients because 100% of those patients had systolic heart failure. And that's a different disease process. But otherwise, the age is very similar to what this guy would be. And I actually designed this case. It's not a real patient. I kind of modified a real patient to make him look like a patient in any one of these trials. And so my argument for you would be that we can actually do a good comparison between these trials to look at how they compared to each other based on the similarity of the baseline characteristics of the patients. In terms of medication management, there were variations. The one thing I would point out is that my assessment of these trials is that for the most part, these are reasonably well-treated patients. And you can argue about, some of these numbers. The beta blocker in, Compass PAD was a little lower, but that's because they all complained because their claudication got a little worse. But in general, these are well-treated patients, in contrast to many of the agents that you guys use for not residual, but for primary risk management, where the actual other treatment wasn't that good that supports the older agents that we use. These are all well-treated patients. So then what I did was I said, okay, well, let's look at their event curves and see how they line up, and then we can easily decide which drugs to give. So here's a paradigm, placebo, and it goes right off the graph because heart failure is a bad disease and patients die. So they disappear fairly quickly. Entresto works. There's a PCSK study, probably Fournier maybe. There's an SGLT2 placebo study, so perhaps those patients are dying a little less often. This is also a way to see if you're comparing apples to apples, because if the placebo or control patients line up quite well, then you know that the event rates are similar, and therefore it's reasonable to compare them. Here's the COMPASS study looking very much like EMPA-REG. There's PCSK treated patients who then looked a little bit like the COMPASS patients. There's the EMPA-REG treatment arm. There's the COMPASS treatment arm. There's DAPA-HF, again showing that heart failure patients don't do well. And what's actually impressive is the way those curves line up from Paradigm and DAPA-HF. But the bottom line is that if you look at this graph, most patients who are looking at residual risk are kind of in this area, except for these heart failure trials, which is a completely different population. And I think that when you're thinking about management of residual risk, the first thing you have to ask yourself is, does this patient have systolic heart failure? Because if they do, you're looking at different things. So the next thing I did was I said, okay, well, I've got my baseline characteristics. I think we're comparing apples to apples except heart failure. What were the event rates in the trials, kind of in a number way, so that I can manipulate numbers and do mathematics. And what you've got here is if you look at the bottom half of the slide, the event rate in the control group, and what you can see is, again, the heart failure patients have more events on a year-by-year basis. You've got the event rate on intervention, you've got the absolute risk reduction, the relative risk reduction, and then the cost per day the last time I checked ODB formulary, or where the drug isn't covered, some other formulary. And you can see that I highlighted the outliers in red. You'll see that the outlier from a cost perspective is perhaps the PCSK9. And otherwise, and I suppose a little bit Entresto, but otherwise all the drugs are in that sort of $2.50 to $3 per day range. So you can then do a little bit of math and say, well, given that the outcomes that we're measuring are similar, right? They're all MACE plus death from cardiovascular causes. We can then look at the relative risk reduction and how much do you spend for every % relative risk reduction that you get. And what it turns out is, if all you care about is money, which I'm sure is not the case for any of you, the cost per relative risk reduction per day is 10 to 12 cents for rivaroxaban 2.5 BID or for dapagliflozin in a heart failure patient. And then it goes up from there with the SGLT2 that a lot of you guys said you were favoring. At around 19 cents per day, although this guy has heart failure, so actually his costing will go with the DAPA, so you guys were right on with that, the Entresto data and then the PCSK9 data. So that's one way of kind of looking at how do we decide which residual risk treatments do we give. There's, you guys have all seen this, I'm not going to spend a lot of time, but there's lots of cardiac disease, which is why this building exists and why you guys are sitting here. This slide is one that you show your administrators, or when you go as an ACP Ontario ambassador to your member of provincial parliament, this is the slide that you show them to justify them actually investing in managing patients with disease in more than one vascular bed. So the sicker the patient gets, the more they are going to cost you. And the more investment you should be strategic about making. In terms of just a few comments about these agents, because the first was just a lump them all together. This is an attempt to split a little bit. These are the SGLT2s for CV protection and diabetes. So Empareg or Canvas style treatment. And again, about a 20% relative risk reduction overall. This is GLP-1s, which I didn't cover in the slide, but again, are an option with about a 10% relative risk reduction for residual risk. This is the Fourier and Odyssey trials, again showing the benefit of the PCSK9 inhibitors. This is the icosapent ethyl with the stock markets favoring it. And it is a pretty impressive result, coming in at about $10 a day. What about antithrombotic, antiplatelet agents, and how do you decide on this? So the reason that I thought it would be worthwhile talking a little bit more about this is that fear-based decision-making is a bad idea. And we're being inundated with fear-based decision-making now with this whole coronavirus thing happening. When you allow fear to modify your decision-making, generally you make the wrong decisions. And anticoagulant and antiplatelet therapy, I think, is an area where we're often tempted to make fear-based decisions. So patients will say, you know, I was taking that blood thinner and, you know, I bled from my bowel and my family doctor told me never to take that again, which is a fear-based perspective. And then you look at their file and you see that the colon cancer that actually you exposed by giving them the blood thinner was removed, and that really you have source control, and it would be actually a really good idea to restart the drug. But one of the troubles when you start thinking about managing patients with drugs that increase bleeding risk is that you have to guess where they are at on the spectrum of vascular events. And if you work at the Heart Institute, chances are most of your patients are at the far end. They've already had established vascular events that have landed them in your care. But when we are thinking about the various options that we have, so, you know, aspirin-based therapy, which patients in this, oh, by the way, this is a great little review article if you're interested. It was just published. And I learned a new term from this review article, primordial prevention. So primordial prevention is, have any of you heard that metformin extends life in non-diabetic patients? Is that something? So yeah, so there's this book out and this guy's promoting this idea. So that would be an example of primordial prevention. So there's absolutely nothing wrong with you and you just want to live longer, so you take metformin. My family doctor actually refused to give that to me. I tried because I was interested in it. But anyways, you know, in the other ranges of disease, so primary prevention, there may be a role in individual patients with very high risk based on risk factor calculations in some patients. And there's ways of figuring that out. Secondary prevention, they're either on aspirin, they're on dual antiplatelet, they're on dual pathway inhibition with low-dose Riva and aspirin. And then some of your patients, unfortunately, end up needing triple therapy at some points in their life. And so, you know, how do we use these agents well? This is just a little bit of data that you're familiar with. This is the data looking at dual antiplatelet therapy. And I would say that, you know, there's a big difference when you move from single antiplatelet in Capri over to Charisma all the way through, where there is data showing that event rates are lower in the patients who end up with dual antiplatelets. And this resulted in the 2018 guidelines that you guys are familiar with around sort of after a PCI or an NSTEMI. Give them dual antiplatelet, aim for a year, at a year look at bleeding risk and then decide whether you're going to continue or go to single antiplatelets. And this 2018 was the first time that they brought up this idea of dual pathway inhibition. I want to take a step back for a second. How many of you remember reading this? And if you say yes, it'll date you. So this was like 1990, and this was the Waris trial. And this was exactly this scenario with the same types of patients. Now, they weren't getting the same kind of stents that you guys are putting in now, but it was just warfarin adjusted to INR 2 to 3 versus placebo. And if you look at this, warfarin in this context was associated with, well, first of all, I would say look at the event rates, huge, but 35% reduction in death in this study, which completely kills the antiplatelet data. And if you, this is again the antiplatelet data looking at their various outcomes and durations of treatment. But the bottom line is that there was no reduction in mortality in these trials. And if you apply, this is the dual pathway thing. Oh, I missed, there's one slide in here that I wanted to give you. But the bottom line is that if you actually do a calculation of the number of events prevented, you'd be much better off using warfarin adjusted to an INR of 2 to 3 compared to dual antiplatelet treatment. Having said that, we don't do that because we're not influenced by Doug Ford, and it's not worth, like the challenge of managing warfarin well exceeds our threshold for saying that we ought to be doing that. But it is worthwhile to sort of take a step back. But this idea that antithrombotic therapy is helpful is part of the rationale for this idea of dual pathway inhibition. And there's other places where this came from, but the bottom line is that probably your most effective way of managing this is to get the right dose of antithrombotic, the right dose of antiplatelet therapy. So this is just some background to the COMPASS trial. I'm not going to belabor this, but you guys are probably familiar with the Alice TIMI 51, where it was immediately post-event patient in CCU randomized to the 2.5 BID of rivaroxaban with aspirin, and there was a reduction in event rates, but there was also an excess of bleeding risk that affected that trial. And then the COMPASS trial was just looking at the other end of the extreme, where I think the time from last MI was 7 years in COMPASS. So in the stable setting, large trial, and those were the outcomes. The typical COMPASS patient looked just like our man that I presented at the beginning, 68 years old, had CAD, had a prior MI, had PAD, that sort of thing, and most were reasonably well treated. These are the primary outcomes that you've seen before. The one thing I would say is that I wish they had continued the trial for another 2 years, because if they had, I'm betting that the 5 BID dose of Riva without an antiplatelet agent would have been actually statistically significantly better and might have given us some other options to consider depending on the patient scenario, but that's speculative. In terms of outcomes, they looked at the CAD, the patients who entered the trial with CAD as the primary reason to enter versus those who entered the trial with PAD. And not surprisingly, the PAD patients die more often and have more events. You can see that the aspirin-treated patients, it was around 5% with CAD versus about 7% with PAD. The reduction in risk was somewhere between 22 and 28%, depending on which population of patients you look at. And there was a cost in terms of bleeding. So these are the primary results. And interestingly, from an absolute risk perspective, the amount of benefit in terms of preventing MACE was almost identical to the increase in risk of bleeding. And so when the paper first came out, people said, well, you know, I don't know, like, how do you rate a bleeding event versus a coronary event? Given that you guys are all working here, you guys obviously do the right thing and think that coronary events are much more important than bleeding, probably at a 2 or 3 to 1 ratio kind of thing, which is why you're not afraid of bleeding. One of the really interesting things about the bleeding data was presented in this table, and so I don't know if everybody's seen this or not, but the bottom line is that they did a time assessment. They looked at when GI bleeding events occurred, and actually this is primarily GI bleeding that drove this, but if you look at the middle section under major bleeding on this slide, what you will see is that within the first year of the trial, there was an excess of GI bleeding in the group of patients who were getting dual pathway inhibition compared to aspirin alone. Had the trial ended at 1 year, you might then make a judgment that, and actually when they scoped these patients, they had colon cancer. You might make an assessment that for some reason Riva causes colon cancer. But what happened over the course of the trial is that they evened out, and by the end of 3 years, the diagnosis of colon cancer was actually equal in both arms. It's just that it was being unmasked early within the first year in those who got the dual pathway treatment. And so I actually advocate for all patients at the age of 50, rather than doing it when you do that fit testing, they send you the package. What you do is if you take a week of, your favorite NOAC agent and then do your fit testing, then the sensitivity for colon cancer goes up dramatically. So I haven't managed to convince the government to sort of support that yet, but we've actually, in our anticoagulation clinic, we do an AFib anticoagulation clinic. We've diagnosed 4 people with colon cancer. Our strategy is we make sure there's a hemoglobin level within 6 weeks of initiation. We repeat it 6 to 12 weeks later, and if there's a 10-point drop, we investigate. And doing that, we've uncovered 4 patients so far with colon cancer, and they've all been treated. The primary results of the COMPASS trial you're familiar with again, and it was an effective trial, reducing MACE by 24%, CV mortality by 22%, and all-cause mortality by 18%, at a cost of a 70% increase in major bleeding, which, if you look at the absolute risk, is 1.2%. And there's an indication now, along with all of the antiplatelet agents that we use to manage residual risk, there's also an indication with rivaroxaban from Health Canada. Where I think that the COMPASS data really shines is in the patients who entered the trial with PAD. And when I'm looking at sort of low-hanging fruit, where dual pathway treatment makes the most sense, it really is in these patients with PAD. Up until this trial, when I saw a patient, because I do work for the vascular surgeons at my site, and when you're seeing a patient with gangrene in a toe or something like that, we really had nothing that we could say, definitely I can lower the risk of you ending up needing an amputation. Until this came out. And in this trial, the risk of amputation was reduced by half if the patients were appropriately placed on dual pathway inhibition. And so for the first time, I actually have this. And when I see patients with the gangrenous toe who are going for an aortic biofem, and I say to them in the pre-admission clinic, there's this drug that I wouldn't start now because it's a blood thinner, but it's been shown that patients that take it have a halving of their risk of going on to have an amputation. I find I've had no patients say, you know what, doc, I prefer my bag of herbals, and I'd rather just stick to my herbal therapy. Whereas I get that a lot when I try to promote statin therapy to them, or some of these other residual risk management strategies. So I think that is one area where we have the biggest bang for our buck. This is actually the numbers, and again, this is an interesting area where perhaps the 5 BID dosing of rivaroxaban would have been an interesting thing to pursue. But right from about 6 months onwards, the curve separated and stays separated throughout for major adverse limb events. I think, if Sonia Anand was a man, I wonder if we'd be calling this male, because she's the author on the I don't know if it was her idea to call it male, but anyways, that's a side issue. They looked at a number of different groups that you guys interact with. So GFR is higher or lower than 60. There was no difference in terms of outcome. The number of patients. So one of the questions that I get with this is, okay, we kind of have an idea of what we ought to be doing with Riva 15 or 20 in patients with AFib. What about the lower dosing in the setting of renal impairment? And the bottom line is that there were some patients in this trial with GFRs down to, or creatinine clearances down to 15. There wasn't data below that, so you use that at your risk. These are the outcomes which I've already gone over. One of the topics that I wanted to cover before we kind of open it up to just discussion is, should residual therapies ever supplant initial therapy? So, if you think about, I kind of broke this slide down into good ideas for all humans versus initial therapies that, patients should be offered versus residual management. And some of the examples of good ideas for all people that we should be encouraging our patients to do is normalizing their weight, exercising with a fitness coach, for example, eating a healthy diet with a chef, hire a chef to come into your home to help you cook really nutritious food. Manage your life stress with a lifestyle coach. Some initial therapies would be aspirin or ACE inhibitors or statins or metformin. And then my list of residual treatment here is dual pathway inhibition, Entresto, PCSK9 or icosapent ethyl, or an SGLT2 or a GLP-1. So interestingly, those good ideas for all humans were tested in the Look Ahead trial. So Look Ahead took diabetic patients and they did the most expensive lifestyle intervention that you will ever see. So I'm sure they were spending $1,000 a week on these patients because they actually hired a chef to cook with them 3 times a week. They actually hired a lifestyle coach that they had to meet with every week. They hired a fitness trainer who would actually do the exercises with the patient, like, let's go for a run today. Okay. And these are the results. So thousands and thousands of dollars on lifestyle intervention in diabetic, reasonably high-risk patients, absolutely not a stitch of evidence that it helped from a cardiovascular outcome perspective. So don't feel bad about that cath study. Aspirin in diabetic patients. So, bad diet, and these patients in Popadat actually had low ABIs as well. So, ABIs of 0.9 or less. Again, no evidence that aspirin is helpful. What about metformin? So this is the UKPDS 38 trial. And what I see is just a bunch of lines that are kind of like lying on top of each other. And then the sulfonylurea part of the study started later, so that's why there's actually 2 sets of lines that lie on top of each other. They had 181 patients in this metformin trial. This is why you guys offer metformin to all of your diabetic patients. They had 21 patients in their analysis at 15 years. 0 patients were getting statin. 15% were on any blood pressure lowering drug. They weren't using ACE inhibitors then. And this is why we give metformin as an initial therapy. If you compare some of the other things that we do, these are actually the results. And certainly in these extremely well-treated patients, and I would say that in this graph, probably the best treated patients were the COMPASS trial patients. There's far more data supporting the use of these residual risk therapies than there is for the initial treatments that we offer. And so it's an interesting thing because we have locked ourselves, like I'm a believer in evidence-based medicine, and I love McMaster. But our system, the way we write our guidelines, and I am part of the hypertension guidelines, is that we've locked ourselves in so that the patients who are getting SGLT2s were offered metformin. And so we are only offering SGLT2s to patients who are already on metformin. But I would challenge you to think about the idea that at some point we're going to have to try to deconstruct the model that we have set up so that we can give the treatments that we think are most effective in a rational way. Because one of my other pet peeves is complexity of therapy. And this stacking of medication that is dictated by the timeline of when these studies come out requires complexity especially when you're managing residual risk. And the way to help our patients the most is to help them deal with complexity in a way that they can be adherent to the best therapies. And that is sort of the challenge, I think, of the next 10 to 20 years, is to try to figure out a way of looking at the data that we have in a way that then allows us to simplify management so that patients are getting the best therapies. So with that, you can tell me how you're feeling, which gives me a sense of what to do now. We have about 15 minutes left, and I'm very interested in conversation or questions if there are any.